slideshow, or can you see it's a series of things?
A series of slides.
Okay.
Yeah.
And now as the main slide.
Yeah, that's perfect. Thank you.
Hey. It was on the wrong browser. So I won't repeat myself, but here's the pretty pictures you should have seen. Sunburn, blisters, so superficial and partial thickness, then full thickness, and then really horrible full thickness with bone. Are they moving on? Yes, great. So I was just saying how great the British Burn Association is at doing sort of prevention stuff, because that's better than cure. Even in 60-degree water, so a cup of tea you've made, and even put a bit of milk in, if you've got 3 seconds of contact with that, you can get a partial or full thickness injury. 69-degree water, that happens in a second. So just a little bit of temperature increase. Cooking oil, flame burns, fire coals. We see that in sunny Cornwall. Kids step on barbecue coals that are left on the beach. So we get, you get a lot of heat coming out of those. So the main things to do with any burn, again from the BBA, is cool the burn with running cold tap water for 20 minutes, which is fine so long as you've got running cold tap water. And you need to keep doing that until it stops feeling like it's burning. Call for help or advice. And then they advise covering with cling film or a sterile, non-fluffy dressing. So cling film's great because you can see through it, so you don't have to keep taking off the dressing. And the thing about burns when they're partial thickness is that they're very painful. And so the air going over it hurts, and putting cling film over the top stops some of the pain as well as keeps it nice and clean. They also teach kids to stop, drop and roll. So if your clothes are on fire, then they're supposed to stop, drop and roll. They say kids can get confused about that, and they sometimes start doing it when smoke alarms go off, but better to be safe than sorry. So management of burns. If the burns occurred and they've come to the emergency department, what we mostly see is partial thickness burns, as I've said, often caused by hot water. So we need to assess all our patients according to ABCDE, but if it's an isolated, fairly small area burn, then we focus on that. So we would want to know the body surface area affected. So it's less than 10% in children or less than 15% in adults, then we don't need to worry about fluid replacement and things. But we'll come on to some more serious burns later in the talk. Everybody needs pain relief. And then if they've got tense blisters, then we need to de-roof them to remove the devitalized skin, because that harbors infection. Otherwise, the main risk being getting infection around the burns. We should dress them with non-adhesive dressings, and then we bring them back at 24 to 48 hours. And sometimes at that time, the burns progressed a bit, and so we might need to take off more of the dead skin. If people have got burns in what we call special areas, so the face, hands, over the joints and the genitals, then we need to refer to a burns facility at least for further review. I'll come on a bit later about how the UK is kind of divided up into who deals with the burns. So Cornwall doesn't even get facility status. We're just a hospital, but there's burns facilities, burns units and burns centres. In kids, we've always got to consider non-accidental injury as well. But what we don't do with burns is we don't put creams on them because that doesn't really help. It can make them more likely to get infected, makes them less easy to assess, follow up. And we don't give prophylactic antibiotics either because of a large risk of organ resistant infections. So how do we assess the percentage of burns? We've got lots of good tools. The rule of nines is what I always learned in the olden days, where you look at a patient and you think, right, they've got 9% is their head, 9% is the arm, the whole front's 2 times 9, so 18, the whole back's another 2 times 9, 9% on a leg and 9% on the front of your leg and 9% on the back of your leg. And the whole thing comes to 99, and then you get 1% for your genitalia as well. So you kind of estimate how much of the body surface is burnt. In this estimation, we only include the partial thickness and full thickness burns. We ignore that sunburn, superficial burn, because the thing is how much of the skin, the dermis, it's breaching, and that's what depends on our fluid resuscitation and a lot of the other care we need to give. Really good app, the Mersey Burns app. Saves you having to do maths, and you just get to do drawing, and you colour in your little man as to where the burns are, and that calculates a percentage for you as well. So for example, this patient here has got some on his arm. You can do full thickness and partial thickness on there, and it gives you a percentage. So when we're looking at people with burns in Cornwall, because as I said, we haven't quite made it to facility status, we need to consider a few things to guide where we refer these patients onto. So we need to think about the total body surface area. We need to think about the depth of the burn injury. We need to think about the anatomical site of the burn injury. We need to think about the mechanism and other factors that may impact on the severity or complex of burns as well. This is a bit of a wordy slide, but all burns more than 2% total body surface area in children, or more than 3% in adults, which actually isn't that much, and we should be discussing at least with our burns facility, which is in Derriford. All thickness burns should be discussed because they just don't heal on their own. Also, circumferential burns should definitely be discussed and probably dealt with rapidly. Burns that don't heal in 2 weeks, we should get further advice for. And any burn with suspicion of non-accidental injury as well should be seen in a burn unit or centre. I've already said hands, feet, face and genitalia are special areas. Also, we don't often see them, but chemical, electrical and friction burns as well, because they just don't heal as well because of the amount of tissue damage. And if we see burn wound changes at our follow-up or signs of infection or there's concerns of toxic shock syndrome, then we need to be aware of that and refer them early as well. Very busy slide, but this luckily is on our resus screen, and I've used this a couple of times. So as I say, we do see smaller burns fairly frequently, but we fortunately don't often see major burns. And when we do, they stick in all of our minds, and we need to be sure who we're talking to for advice. Now we're in Cornwall and our nearest burn centre is in Wales. So it's over 270 miles away. So it's a long, long way. And we need to be, if we're transporting patients there, we need quite a lot of resource, but they're very helpful to talk to as well. So yeah, our local burns facilities, Plymouth, then we've got further help in Bristol with the burns unit, and the main centre for adults is in Wales, although the centre for kids is in Bristol. So I'm just going to talk about a bit of a sad case, actually, sorry to end, but this is one of the major burns cases we've had recently at Truro, and we discussed this at our Tackling Trauma meeting just yesterday. So first, 42-year-old male who had a bit of a fight with his partner after finding out she was pregnant, and poured liquid paraffin all over himself and lit himself on fire. So unfortunately, most of our significant burns we do see in adults is from self-harm. And his dad found him rapidly, put him in the shower, ran the cold water for 20 minutes and called 999. So did all those right things on the sort of initial first aid. By the time the patient got to us in Truro, they already had stridor, so there was concerns about the airway. They had evidence soot in their mouth, their tongue was black. They were wheezy. SATs were okay, so he was still managing to breathe at that point on his own. Heart rate was up, understandably. Blood pressure was okay. It was GCS 15, but pretty distressed, as you can imagine, and in severe pain. So he had, we estimated, 40% full thickness burns to his head, his front and back of his torso and both arms. And he had further secondary burns, so it's not second partial thickness burns, to the backs of both legs. He was given oxygen, he was given morphine, IV morphine for pain, and paracetamol for pain. He was given fluids, and we'll come on to how much fluid we give. And he was tried to keep warm in warming blankets and foil, even prior to coming to hospital. He was closest to here, so he came here rather than going to the major trauma centre. This is really shocking, these pictures. So yeah, this kind of shows the black charred burns that this patient has sustained. And you can see, especially on his chest, they go all the way around. So there are circumferential chest burns there. and also parts of his arm. We were worried about whether they were circumferential as well. So what are our priorities for care for significant burns? Well, ABCDE is really, really important. Impending airway problems are the biggest problem we see in significant burns. This chap already had stridor pre-hospitally. By the time he arrived in hospital, he had a very hoarse voice, and fortunately, early intubation meant there was still a small hole to get the tube down into. So he got intubated before the swelling occurred, and we weren't able to intubate him. But we did have front of neck kit ready as well in case we'd need to do that. We were worried about his circumferential chest burns. So he was, once he was intubated and ventilated, we were able to ventilate him, but we were aware that if it got harder to do this, or if there was real constriction, then he might have to have escharotomies, where you cut down the side to just relieve some of the tension in that chest. He's obviously got more than 15% body surface area burns, so he was going to need fluid replacement because you've lost that barrier where you lose fluid. The Parkland formula is what we use, and it used to say 4 mils per kilo for replacement of fluid. It's got a bit more conservative. So in adults, we tend to use 3 mils per kilo per percentage burn, and in children a bit less, 2 mils per kilo per percentage burn. You calculate that amount, and then you give the first half in 8 hours since the injury, and you give the next half in the next 16 hours. In our D part, I've sort of thought about extremities a bit here, and we were considering escharotomies as well in his arm because he did have a band of constriction around that from burns. The main problem often in these patients, once we've secured the airway, is thermoregulation as well, because they just lose a lot of heat through the skin deficits, and pain relief, opiates. Full thickness burns don't hurt that much, but partial thickness burns are very, very sore. So as I alluded to, we're a long way down in Cornwall. Thought I'd show you a little map of our geography. But this chap needed to go to Swansea, which is that white star up in a little bit of blue Wales up there, 238 miles away. By road, that is going to take a long time. So we were fortunate to be able to get, it was the middle of the night, but we were fortunate to get the search and rescue helicopter to transfer him. I wasn't on for the transfer, my colleague Mike did that, and it was a fairly hairy transfer. The other stars we can see a little black star in Devon, and that's the Plymouth Burns facility. And then we can see in Bristol, there's an orange star, that's the Children's Hospital, which is their burn centre, but that's still 170 miles away, a good 3-hour drive, even if you put your foot down. So yeah, our significant burns patients often need to go by air if we can. So I think I'm done my 20 minutes. I've tried to whistle stop cover minor burns and major burns, and sort of talked a bit about our challenges of geography and how we transfer our patients. Any questions? This is Mr. Burns at the end, for those who don't know him.
Thanks very much, Anna. That was really, really interesting. And feel free to put any questions in the chat if anyone doesn't have ability for a microphone.
So it's working.
I have a quick question, Anna. So for the initial management of burns, obviously pouring cold water on it for 20 minutes in the initial stages is what's advised. But at what point do you then start to worry about heat loss? So if the patients come to you sort of maybe half an hour or 45 minutes or longer after a burn, what takes precedence at that point?
Thanks, Ollie. That's a really good question. And you're right, because we often see children with burns that we're pouring water onto, and they especially get cold really quickly. So if it's not a large percentage body surface area, I've literally had a child sitting in cold water and the cold tap running, but having a woolly hat on their head. So you're trying to sort of stop heat loss in other places, although you're cooling the burn. The thing I've noticed with cooling the burns. It says 20 minutes, but actually when we took that child out of the cold water, they screamed again. So it was clearly the burning process wasn't over. So it's as long as you can do it for without getting them colder. With the patients like you saw in the picture, with the amount of significant burns, unfortunately, quite a lot of the damage is done by that point, and actually trying to keep him normothermic was the main priority for him. There's obviously a lot of in-betweens. So I'd say cool the burn, but warm the patient in any way if you can. So you could give him warm IV fluids as well. So that patient who had significant burns on his January transfer in the middle of the night was getting cold in the helicopter, but he could have warm fluids to keep him warm internally as well.
Great, thank you. I think in the interest of time, I think we'll move on to Bitok's talk, who's going to be talking about the nursing side of wound care and also burns management. But thanks so much, Anna. That was really, really interesting.
Really sorry, because I'm clinical, I won't be able to stay to listen to Bitok's talk, which is very rude of me, Bitok, but I'm sure it'll be excellent, and any learning points will be gratefully received. Thank you very much.
Okay, Anna. Nice to have you. Nice to hear from you.
Nice to see you, Bitok. Okay.
Looking forward to seeing you.
Bye-bye.
Bye.
Anna, bye. Bitok, are you able to share your screen, or I have your slides if you're unable to?
Please do share for me. I think
Okay, perfect. So what I'll do is I'll share your slides, and then if you just let me know when you want me to change the slide.
Okay.
Just while we're doing that, I've just been having a look at the chat function, and I think we've got a message from Bahar that says, awesome, many thanks, Anna. Much of the Kenyan population love cream for burns, so lots of community engagement needed here. So it'll be interesting to hear from Bitok what kind of things you use for your burns. And then Casso has sent a question asking, how do you do a chest escalatory? So unfortunately, Anna won't be able to answer that question, but I'm sure it's something we could ask her separately.
Oli. Hello, Oli.
Hi, I'm just getting.
Hello, can you hear me? I think mine has gone through.
Ah, perfect. Yeah, I can see them. Great. So when you're ready, Bitok.
All right. Yeah, thank you. So I'm Stephen Bitok, a registered nurse at Nanyuki Teaching and Referral. We'll be taking you through two presentations. And in the interest of time, we shall begin with wound care with a patient having a psoriasis. So the patient is a 36-year-old female who came in with 2 leg ulcers, one on the right and the other one on the left. The right leg ulcer had been there for 4 months, and the left one had been there for 2 weeks, had a necrotic base and surrounding erythema, normal base. So this is how the wound looked like. The larger one being the right one and the smaller one being on the left side. So now, before we continue, usually there are 4 stages of wound healing: hemostasis, and then followed by inflammation. Then there'll be granulation followed by maturation. This wound, the wound we are looking at, was stuck in the inflammatory phase. The larger one had started up as a psoriatic plaque, which later on turned into a blister and then became a sore. So the other one had an insidious acute onset, and 2 weeks later it had it seemed as above. So when the patient came in, she had a lot of pain, and yeah, so we managed from there. So I won't talk much about the history, but we'll move on to the comorbidities in the interest of time. So the patient had presented with 2 major things. The first one is psoriasis. And as you know, psoriasis is an autoimmune disease. It could possibly inhibit the brain from sending signals that there is a wound, a sore here that needs to be healed. So the other one was there was low HB and the patient at the time was on hematinics. We sent the patient for nutritional review, and the psychological impact for psoriasis in the patient was that she was unable to have relationships that were constant because her body image was more impaired. We had to also look at the economical impact, because normally what we do is dress the wound today, then on alternate days, and we had to find a solution which is better off. So the next two slides will show a couple of two major things we used. One is debridase, and this one was helping us do autolytic debridement. Debridase has papain and urea. And the slide we see is luofukon. It's a foam dressing, which has 5 layers, a protective backing, which is waterproof, and a bacteria barrier. We have a super absorption layer, which will help minimize maceration risk, especially of the surrounding tissue, non-woven layer, silver antibacterial foam. Of importance at this point, when you talk about silver, is you wouldn't want to, the wounds you get dressing with any silver foam dressing, you don't want to use normal saline, because it will form a salt with silver. So you'd want to use more so distilled water. And then finally, silicone wound contact layer. This is necessary because with any dressing you put on a wound, you wouldn't want it to be so adherent that when you peel it off, it excoriates the tissue that is forming. So the two images you're seeing here is as a result of the above dressing, and we had applied. We started with the right one, so please take note of that. So we had applied every time the patient came, we would clean with the distilled water, then apply debridase, because as you remember on this slide, there is whitish patches, which I told you before is due to neutrophils dying and then staying up there as a slough, and we need to remove it up. So we would lyse it with debridase, and after a while it granulates, and this is how it looks like. So progressively the wound starts, the epidermis, the epithelial layer on top, starts forming and merges together at the center. Remember, we are doing moist wound healing all through, and in a remarkable turn of events, this is how it looks like. That's after 3 months, and we continue. At this point, we no longer have a lot of exudate coming off the wound, but we still want to protect the wound. So we had changed from luofukon to Primapo, which is a lesser, not more of a foamy one, but still has some level of protection to it. So collagen at that point became more tensile, and that's how the wound looked like. And it was really good to see the patient having the wound of the patient having come back to a better way than it was before. Now, on the left one, it appeared more of a venous ulcer, and as we had seen on the initial presentation, around the wound there was more of erythema. So what we had started with was an antibiotic cream, which is a Zupressin, mupirocin, applied it on top after cleaning it, and then on top we applied the luofukon, which I'd shown you before, and that's for the subsequent 2 or 3 dressings before we changed the antibacterial application to debridase, so that we can lyse the fibrin and the slough that was on top, and this is how it looked like. Then we realized that after the wound had granulated well and angiogenesis had occurred, we needed the skin to come close, because the other one was a psoriatic wound. This one had an acute onset. So we applied an epidermal growth factor, which is Regen D, and this one healed a little bit more faster in 2.5 months. This was the outcome. So why wet wound dressing or moist wound dressing? This is because we are promoting autolysis of necrotic tissue, and secondly, the epithelial cells will migrate faster in a moist environment. There'll be pain decrease, especially for this patient who would have witnessed that with the left left limb sore. There's decreased inflammation, decreased scarring as well, and also there'll be precise delivery of topical treatments. As you realize, the normal way we do wound dressing, which I'll mention later on as we finish up on the presentation, we don't really protect the wound from bacteria from the outside environment, which may still have an impact on how chronic the wound could grow. So that's it with the short presentation I was having. The outcome was good. This is how the wound had ended. And on the previous one, this is how the wound ended. And the patient was free of pain and well to do her own things like swimming and going for vacations as she wanted. So I'll move on to burns. And if you have any questions, we'll address that at the end of the presentation. So on my left, there's a photo to remind us how the skin layers are. Quickly to go through, the first degree burns will involve the epidermis only. The second degree will involve they will have two, the superficial and the deep ones, superficial having epidermis and upper third of the dermis being involved. The deep one will have epidermis as well as the upper third of the, 2/3 of the dermis, sorry. So the third degree burns will have full epidermis and the dermis also destroyed as well, leaving no cells to heal. You'll note that they are more gray and charred, as well as black insensate, contracted, pale, and also leathery. Fourth degree involving muscles, and fifth degree having bone involvement. Now, burns might be very, very painful, and it's only in cases like epileptics that convulse during burns who are probably not able to move away from pain at the time. And that's why the fifth degree is usually associated with epileptics who convulse during burns. So this is how we classify our, there are various ways to classify burns, but more so, this is the one we use. So there's Landard Broder's chart, which is on your right as it is with the different ages. And the 1% calculation being the patient's palm representing 1% of the total body surface area. Now that is usually very important while calculating the burns that are less than 15% or the unburned surface for the patients who have over 85% burns. So that having been said, now moving fast because of time, I hope you'll understand, but in case you have any question, you can pop it up at the end of the session. So you'd want to consult a doctor, especially when you're having a third degree or fourth degree. Either way, in the emergency unit, there's always a doctor around here. So we'll use CABD. C is usually involved with the spine trauma, and you'd want to do head blocks or blanket rolls. A for airway. So we're talking about intubation, and as below are the indications for pharyngeal burns included, and all the below. So B for breathing, and you'd want to do supplemental oxygenation, 15 liters per minute on high flow, on non-rebreather masks. So C is majorly circulation, and here's where we have issues with the fluids. The blood pressure is going low because there's a lot of fluid moving out, and the skin is not holding to the skin is not, the skin is already impaired. So how do we calculate fluids here? So for patients with less percent 10 total body surface area burns, those ones are usually resuscitated orally and usually given antibiotics, and then we can manage them from an outpatient view. They go home, then come back. Also, burns that are involving 20% of the total body surface area will require IV resuscitation. And the formula for calculating IV resuscitation would be in 24 hours, 4 mils per kilogram per the percentage of total body surface area. For pediatrics, we use 3 mils per kg per percentage of the total body surface area. So half is usually given out for the first 8 hours, and then half over the next 16 hours. So we usually aim at a urine output of 1 mil per kg per hour in the children younger than 2 years. So if urine is not adequate, you would increase the fluids by 150% of the calculated fluids. Now D for D, will correct hyperglycemia, and also remember we need analgesics because the patient is most likely in pain. So for hypoglycemia, you can take blood sugars, but still you can give it as a bolus, 50 mils of 50% dextrose IV. So for analgesic over here, we use morphine, tramadol, rarely fentanyl, but that depends on the area where you're located in. E for exposure, when the exposure, we're talking about temperature check and warmth for the patient. The more the patient stays exposed, the more the patient is going to feel cold. Even when you're giving fluids, you would want to warm the fluids. So you'll remove all the clothes as well, jewelry, necrotic tissues and debris, and also don't burst blasters. I noted that as a difference with the UK team. So I am a nurse. Definitely, I'll have to talk about the nursing tips. In the neck burns, you'll place a pillow under the patient's head to hyperextend the neck. Remember, if the neck has burns already, I'm concerned about having contractures, and that will start almost instantly as the burns have taken place. Chest wall burns, you will have to consult a surgeon, and not only chest wall burns, any circumferential burns, including limbs. So then you'd want to nurse the patient on 45-degree elevation. You'll evaluate also the 3rd-degree and 4th-degree burns for possible sclerotomy. Remember, sclerotomy, you're removing the dead tissue that's on top so that you can allow the then give tetanus toxoid. Wounds, except for superficial wounds. Now, you might note that we usually don't prefer giving systemic antibiotics. So how do we do a walk-in burn management? First, you'll expose the wound, you'll assess the needs of the wound as with any other wound, then clean with saline. And we said if you're using any silver-based foam dressing, could be Luofukon, could be sorry, what's the other? There's one that's usually particularly very good with the burns. Let me remember, and then I'll say in the meantime. So you'll wait for it to dry, then apply topical antibiotics, because immediately if you apply topical antibiotic on a dry, okay, you may not be able to do that on an emergency case, but for a patient who's a walk-in, you'd want it to dry a little before you apply an antibiotic, a topical antibiotic. Usually we use a Silverex over here, and place biograss on top, put a sterile gauze on top, wrap with a crepe bandage to secure it, and then you can discharge the patient, probably on medication if need be, with a to come again date. So what's the criteria we use over here for patients who are supposed to be transferred to Banting? Now, you might note that around here, we usually refer our patients majorly to Kenyatta National Hospital, which is 194 kilometers away from here. So we refer all our burns lower than 1 year old. all burns that are 1 to 2 years old with total body surface area of greater than 5%, patients with third-degree burns, fourth and fifth, patients older than 2 years with partial thickness burns together greater than 10%. So patients also with burns of special areas, face, hands, feet, genitalia, perineum, or major joints, those ones we refer them so that they can see a specialist of the special area involved. Patients with inhalation injuries resulting from fire or scald burns. I think I might need to mention that during inhalation injury, we usually add 15% of the calculated body surface area. This is usually very helpful with resuscitation, calculation of resuscitation fluids. Patients with circumferential burns of limbs or chest, which we had talked about, septic wounds burns, as well as chemical and electrical burns. So unless anyone has any question, that's where we are. Is there anyone with any question?
Great, thanks.
Or are we together?
Yeah, so if anyone has any questions, feel free to pop your mics on and ask a question or put it in the chat. I have a question, Bitok, about the sort of subsect of patients that come into A&E that don't need referral on, that get discharged home to be reattended and have their wounds checked. Do you find in Nanyuki you get issues with geographical location and patients not coming back for their wounds to be rechanged and redressed?
Well, good question, Oli. I think the major challenge we have is resources. And when I talk about resources, it's because often what we have is gauzes, back by grass, and a normal saline to clean the wound. Now, this kind of dressing will is more likely going to last for a day or two. So you preferably will do alternate day dressing. Now, alternate day dressing will impact on the patient. Remember, the patient has to come all the way from home. There's transport cost. The patient will also have to pay for that if they don't have NHIF. All these factors will make the patient will impair the treatment for the wound we are having, and it could slow the progress, or it could make the wound even get into a chronic level point. So that is our greatest worry. But also, when you talk about geographical area, home-based care is actually more efficient. However, very few can afford home-based care because you would dress the patient in the comfort of their own home. So some do source for a nurse who can continually do that, but very few can afford that. So not many can afford. That is a challenge to a couple.
Thanks, Bitok. Any questions from anyone else?
I have a question for Bitok. Thanks so much for sharing. It's interesting to hear kind of Anna's experiences of burn management in the UK compared to what you're doing here, and quite a few similarities and differences there. One thing I'd quite like to know is what's the cause, or the kind of one of the most common causes of burns that you see in Kenya?
The most common cause, because no one wants to feel burned, so it's usually convulsions. That's the most common cause, followed by homicides. We had a case recently of someone who was trying to set himself up on flames. The other case is usually electric exposure to bare electric wires. We also had a recent case of the same. Yeah, I think the three are usually the major ones around here.
Just to add that I think the interesting thing about Kenya is actually a lot of people don't really seek a lot of healthcare when you have small and partial thickness burns. You do have to be basically on your kind of deathbed to be able to come into some of these hospitals. And it's exactly as Bitok says, basically a lot of this is kind of funding issues that people here just don't have the money to go and, you know, like for example, in A&E, you would see quite a lot of kind of burns and partial thickness kind of burns and superficial burns in a minor injuries unit, which is actually kind of different to Kenya because of the way that healthcare is undertaken, I suppose. So it's a really interesting point that you make, Bitok, that lots of your past cases have been all, you know, verging on the kind of major burn side or complications of badly managed wounds, which is a very interesting difference to practicing burns management here versus burns management back in the UK.
Thank you, Barry.
Any other questions from anyone or anything anyone wants to ask in the chat?
So the kind of dressing I was talking about that's usually very good, also silver based for burns, is usually Aquacel. And the reason why I'm talking about Aquacel is because usually when you dress it post cleaning the wound on the burns, is that it will sufficiently sap the exudate, and it will also fit on the dead space, thereby not allowing any bacteria to grow around the area. So Aquacel is really good for the patient I've dressed before.
Mimi imeandikwa record.
Great, thank you so much. I don't think anyone else has any questions, and if you do, just please butt in now. So great, thanks so much, everyone. We are currently trying to collect some information about the grand round, so we're going to post a link on the chat now for some feedback. It'd be really, really helpful if you could fill it in and give any pointers and suggestions for next teaching topic, if you have any. No. And if you fill in your name and email as well, there's the option there to have a teaching sent to you.
Thank you for the very wonderful presentations to the presenter. Thank you.
Thanks, everyone. And also, I think for next March, so the second Friday of March, which is the 12th, we're hoping to have a talk on critical care in the emergency, critical care in Kenya and in UK, and how the partnership, the Dharura partnership is developing with that.
Great, so thanks so much, everyone. I'm going to end the meeting now and look forward to seeing you next month.
Nice to see you. Thank you.